كده شغال.
انا عايز افتح الشاشه.
عايزها فول سكرين.
Thank you for the nice introduction. My lecture is managing diabetes in low and middle income countries. My agenda: diabetes is a growing burden in low and middle income countries. Key risk factors for type, I will speak about key risk factors for type 2 diabetes and the challenges to diabetes care in low and middle income countries. Also, how to overcome the challenges to diabetes care in low and middle income countries. Diabetes is a growing burden in low and middle income countries. In 2025, number of people live with diabetes are 588.7 and expected to increase by 45% at 2050 to 852.5 million. Nowadays, 1 of 9 people live with diabetes. Unfortunately, 43% of these cases are undiagnosed. This is the classification of the World Bank Group according to the level of the economic state of the country. As you see, the dark green countries, America, Canada, Australia, Gulf area, Japan, few areas in the world are high-income countries. Most of the countries are either low-income countries or middle-income countries. Africa has the largest number of low-income countries. This slide shows in the MENA region the percentage of people with diabetes is high, is one of 6 have diabetes and 1 of 3 are undiagnosed. In Africa, in sub-Saharan Africa, 1 of 20 have diabetes and expected to increase by 142% in 2050. In the Middle East, this is the following, the MENA region, this is the following region in the rate of increase of diabetes at 2050 will increase by 92%. In South Asia, the expected rise in people with diabetes from 2025 will be 73% at 2025. 80% of people with diabetes in Africa are undiagnosed. In Southeast Asia, 1 of 2 are undiagnosed. What are the key risk factors for type 2 diabetes and the challenges to diabetes care in low and middle income countries? Key risk factors for type 2 diabetes are obesity, genetic susceptibility, smoking, viral infections, and pesticides. Number 1, obesity and overweight. Obesity and overweight increased markedly worldwide, but specifically in the MENA region has marked increase in the rate of the obesity. And this is related to 2 main things. Number 1, nutrition transition, urbanization, economic growth in some regions, and weak local food systems increased access to processed junk food and shifting diets from healthy options to unhealthy fast foods, high in refined carbs, unhealthy fats, and sugary drinks. Also decreased physical activity due to shift from manual labor to sedentary jobs, lack of awareness of exercise benefits, gender-based mobility restrictions. In some regions still, until now, women are kept in home. Limited access to affordable fitness options, gyms, ability to exercise, to clubs, and so are not available in all regions, and if present, they are expensive or costly for the patients, for the people. The global prevalence of obesity and its related health complications is on the rise. 1 in 8 people live with obesity, according to WHO estimates. In 2022, 2.5 billion adults were overweight, including 890 million with obesity. And obesity is higher in women, about 1.5 to 2 folds than men. In the presidential initiative Meet 100 Million Health in Egypt, 50% of women were obese and 30% of men were obese or overweight. In South Africa, 60% of women are either overweight or obese, and 31% of men are overweight or obese. This slide shows the rate of growth of obesity in different regions of the world. As we see, in Southeast Asia, the rise of obesity is more than 10%, more than 100% between 1990 to 2021 in South Asia and Southeast Asia. In southern sub-Saharan Africa also, the rate of rise of obesity is high, and in the MENA region the rate is high also, 39% in men and 76% in women. These regions contain many or most of the countries in these regions are either low-income countries or middle-income countries. Genetic susceptibility is another factor. High consanguinity rates, especially in MENA region, according to traditions, alongside multiple single nucleotide polymorphism, interact with environmental factors, increasing genetic vulnerability to type 2 diabetes. Smoking raises the risk of central obesity, type 2 diabetes, and its complications, also lowers treatment efficacy. Pesticide exposure, direct exposure to pesticides in farmers, or the more common, the indirect long-term low-dose exposure in food, in general population contaminated food. Virus infections, many virus infections are linked to increased risk of diabetes, as hepatitis C virus, HIV, and the high antiretroviral treatment in HIV patients, and COVID-19, all these factors increase the risk of type 2 diabetes. This study was performed in Sohag University in Upper Egypt, and found that certain age groups from 35 to 65 are highest risk for type 2 diabetes. Females also have higher risk steroid use, high carb in food or fat in diet. All these factors are associated with increased risk of diabetes, sedentary life, hypertension, family history of diabetes, HCV, and BMI more than 25 all these factors are risk factors for diabetes, and waist circumference more than 90 centimeter in males and more than 85 centimeter in females. All these factors are independent predictors for type 2 diabetes in Upper Egypt. This study, which is the International Management Diabetes International Diabetes Management Program in 22 low and middle income countries in different regions of the world, found that more than 70% of people have more than 70% of people with diabetes have uncontrolled diabetes, their A1C above 7%. What are the major challenges in diabetes care in low and middle income countries? Number one, financial. This is the most important factor. Diabetes rate cost about $30 billion in sub-Saharan Africa, 33 billion in MENA region. The graphs show the lowest income, the lowest financial cost for diabetes in MENA region, Africa and Southeast Asia, compared with North America and Europe. Low public awareness or health illiteracy, poor understanding of obesity and diabetes risk, also poor understanding of the benefits of healthy lifestyle and glucose monitoring are of the factors or screening are the factors which increase the risk of diabetes. Also, lack of knowledge on preventing or detecting diabetic complications early. Treatment barriers, cost, misconceptions, for example, insulin fears and reliance on herbal remedies reduce adherence. Cultural beliefs, stigma, weight linked to wealth in many regions until now, and also there is a fear of some patients to appear to decrease their weight because of some people tell them you are sick, you seem older than before. So and social pressure discourage weight loss efforts. Physician-related factors. Most people with diabetes are managed in primary care by primary care physicians or family physicians. Physicians' shortages and excessive workload reduce the quality of diabetes care in the low and middle income countries. Knowledge and screening gaps and familiarity with systematic screening delays complications detection and referrals, while overemphasis on glycemic control overlooks cardiorenal risk. Poor guidance adherence, weak resources, poor guideline adherence, due to weak resources, knowledge gaps, and the policy failure leads to inconsistent treatment, worsening of patient outcomes. Policy-related factors, inadequate health care infrastructure, hinder diabetes prevention, screening, early diagnosis, complication management, as A1C, eye, and foot examination, compounded by limited access to monitoring tools and the modern medications and inadequate multidisciplinary care. Lack of structured program and data, absence of education initiatives, mental health support, and local guidelines, registries, delays personalized care and multidisciplinary approaches. Armed conflicts, this is a very important issue. Impact of conflicts on diabetes management. Refugees and displaced individuals face food insecurity, medication and supplies shortage, and disrupted health care. Also increased risk for infection, chronic stress and fear further destabilize glycemic control. All these factors result in poor diabetes management and increased complication rates and mortality. This is a WHO management plan put by WHO to manage diabetes in limited resources, in countries with limited resources. Start with, in addition to lifestyle is the first step, and either metformin or sulfonylurea, then combination of both together. Then basal insulin if blood glucose is not controlled, and glargine, which is analog, is limited to patients with recurrent hypoglycemia. If insulin is unavailable, sodium glucose TZDs are available, or sodium glucose transport 2 inhibitors. In insulin requiring individuals, catabolic, as patients who are catabolic or need treatment intensification, human rather analogs are used. What are the main drawbacks of the WHO management plans or management algorithm? It adopts glucocentric approach, and so many patients remain hyperglycemic, and this will due to the therapeutic inertia, and this exposes them to increased risk of complications. Also, these guidelines does not adopt recent trends in diabetes management, as initial combination therapy, recent drugs, a holistic approach. The process is glucocentric management. How to overcome challenges to diabetes care in low and middle income countries? This needs practical, cost-effective solutions. Number one, promoting low-cost screening campaigns. promoting low-cost screening tools for in campaigns زي BMI, West, blood glucose, and H1C for early detection in high-risk groups. I need low-cost measures or low-cost tools. Encouraging healthy diet and free exercise while debunking myths and misconceptions via media. Engaging civil society, private sector, and influencers for financial and information support. In these pictures, this is Diabetes Day in Cairo University. This is marathon for the Ministry of Sport and Youth. And this is the ASTD campaign in Ismailia since 3 years. This is Professor Nashal Tut, Professor Hazem. And this is educational course for the ASTD with Egyptian doctor syndicate. Upgrading of healthcare systems is also important. Subsidizing blood glucose monitoring tools and essential medications and encouraging generics and biosimilar industry. Generating national guidelines and staff upskilling. Including mobile health in promoting digital care, physician and patient support. And thank you.